So the first thing I'd like to do is kind of give a brief history of what's going on here for you. So how did this start?
Well, basically, I was moving some heavy equipment in a poor position, I guess, and felt some pain behind my back.
Okay.
And then over time, that pain kind of migrated down my arm and then into my lower arm, and then finally I could feel tingling in my fingertips here.
Okay. All right. And so what have you done for treatment up to this point?
Up to this treatment, I've tried massage therapy, some chiropractic work, and I've also seen an MD.
The other thing that I found interesting when we did our initial assessment, this is a quick directed assessment here, was the pain drawing that you drew. If you could describe it again, how you had the, I just love how you did it.
Yeah, well, obviously, you got to draw a little picture, where's the pain coming from, and I drew a picture of a knife stabbing into my back and then a meat hook in my arm, kind of pulling the muscle out. Yeah. That's kind of what it felt like.
Okay, so the patient is in a lot of pain, and in fact, I think the pain level was 8 out of 10 or something
8 out of 10.
Yeah, and it's affecting the way that you sleep, it's affecting the way that you move, everything. So, and in fact, even working right now is difficult because of the injury.
Working is non-existent.
Yeah, exactly. Yeah. Okay, so that takes us through a basic history right there. That is a very brief history. When we first did our assessment, I think we spent about an hour, 20 minutes or something like that going through it. So that is a brief history to kind of give you guys an idea of what's going on. So everybody in the class is looking at how he's sitting right here. In fact, Roger, if we can, let's get you to stand up even. Okay. So we'll just have you stand up like that. Okay. People who are directly behind the camera will be able to see well enough, just an anterior view. Okay, you can see his head is kind of forward like this a little bit, just for the rest of the class to see well. We'll have you turn to the side, just like that. Okay. You can see his head position like that, and we'll go ahead and turn him around posterior view really quick as well. I mean, you can see pretty standard stuff. He's a pretty well-defined gentleman here, and he's got normal muscle mass. It's normal to see the right shoulder a little bit lower because that is more muscle mass there. But you can still see his head is kind of leaning away just a little bit from that side, a little bit forward and a little bit away. Okay, and then one more turn this direction right here, and we can just see. Okay, perfect. All right, so that's your basic initial starting position right there, just the anterior head carriage. So Roger, if I can, I'll have you sit down. Okay. So usually what do most physicians want to do, most therapists want to do, we'll start where the patient has pain, right? We'll go ahead and palpate into that area. And if you palpate in these areas, what do you see? There is actually some muscle tightness in that area for sure. It's actually a lot better than the last time we did it. But yeah,
it's getting better.
Okay.
Thanks to your good advice.
All right, okay. All right. All right, checks in the mail, so yeah. All right. All right. And you just want to go through and examine some of the areas that are damaged as well at the same time, or that the patient is concerned with this injury, okay? All right, so what I'd like to do now is, you can see some tightness, maybe there could be some muscle spasm in this area, a little bit of tightness over the lateral epicondyle for sure as well, is I would assess range of motion, okay? So range of motion, I'm going to take you through some range of motion. If anything is painful or uncomfortable, let me know right away, and don't do anything you think will cause you further injury,
all right.
Okay? So just like we did before, I'd like you to bring your head back as far as you can. Okay, and can everybody see that? His head extension was basically, he goes to about here, and then you can even look at the look on his face, you can just see there's a little bit of apprehension, right?
That's where I'm stopping.
Yeah, for sure. Okay, let's go ahead and have you flex your head forward all the way down. Okay, and how's that?
That's not so bad.
Yeah.
Feels good.
Yeah, it feels better to move this way.
Absolutely.
It feels worse to go back.
Correct.
Okay, what if we have you lean your head all the way to one side?
That's okay.
That's okay, and what if we have you back towards this direction?
Right about there, I'm going to stop.
All right, and what would happen if you went further?
I get a pain here.
So back in the shoulder, yeah?
Back in my shoulder, and also I can feel pain in my forearm.
So pain in the forearm as well at the same time. Okay, let's get you back to neutral. We need to keep you in that position. And if I can, I'll just have you turn your head to one side. No problem?
No problem.
And what if we turn you the other way?
Right about there, I'm going to stop. But again, I got pain behind my shoulder here.
Okay. Yeah. All right. So basic range of motion assessment is giving us some pretty good clinical information right there, right? We can definitely see he has a bias for which direction he wants to use, and this is a good starting point to go into our clinical exam. The fact that he has numbness and tingling means you should probably be doing a neurologic exam. So a basic part of a neurologic exam is going to be reflexes. And the particular reason I was super excited to bring this patient in for you guys today was he has fantastic reflexes. So in our normal procedure, we check the unaffected side first. All right? So unaffected side, we can go ahead and just have your arm right here. Give me the weight of your arm. Biceps reflex, remember that we're going to traction down right here and give a little tap. Okay, and you can see the biceps contract as we do that. All right. Next one's going to be brachioradialis, little tap right there, and you can see the muscles contract. You can feel the arm move a little bit. And then triceps, you can do just from this position, and you can see it pushes my arm down and away. Okay. So C5, C6, C7, approximate spinal levels. We switch sides. What do we see? So on this side right here, I'll try and have his arm out just a little bit like this. Yeah, thanks, Roger. Okay. Like that. And I'm just going to traction down on the biceps. Traction on the biceps. Good reflex. You see a brisk response. The muscle contracts right away. Brachioradialis. Decent reflex. You see the muscles contract right away. Triceps. And I'm hitting it hard, exactly the way we hit on the other side. What happened to the switch? Okay, there's no reflex there on this tricep. And it's just to show that it's in other places in his body, let's have you just sit back on the table. Even his patellar reflex, medial hamstring reflex, all these reflexes are super good on this guy. This would be a 3+ reflex that you're seeing all the way across here, right? Hamstring. If you go into the Achilles tendon reflex, same thing. Just good reflexes bilaterally all the way around this patient. So that is an obvious finding on this individual right here. Basic reflexes, okay? The next thing is if you went into muscle testing, what would you do? You'd start off with our basic starting point right here, checking the unaffected side first, try and pull you forward, don't let me do it. Okay. Hold, and relax. I'm going to push you this way, don't let me do it. Hold, and relax. Let's go ahead and compare the other side. We'll have that fresh in our mind. So on the other side, I'm going to try and pull you this way. Okay. Let me just pull your arm out just a little bit right there. Okay, don't let me do it. Hold, and relax. Not quite as strong as I would have expected, but if we go to this way, I'm going to try and push you. Don't let me do it. Hold, and this is his dominant arm, right? And you can see that I'm putting minimal force. Again, a very positive neurologic finding that you see right there. Cervical compression distraction test, right? Do we really need to do it? We have these firm neurologic signs. You don't really need to do it. I'm just going to do it once for a demonstration here. So if I can, Roger, I'll just have you straighten your spine right up if you can. And if we can, just bring your head back a little bit if it's too much. All right. And if I load into your head like this, how's that? It's not so bad. Okay. All right. What if we go ahead and tilt your head to the side just a little bit more, right about there. Okay. And we go ahead and load in.
Yeah, I'm really resisting there, and I can feel pain in my upper arm.
Okay, you can feel pain in your upper arm even though we've done nothing over that upper arm, right? Couple of things this patient's going to want to know when they're sitting in your office is, what can I do to get better from the situation? The patient has already told you what makes him feel better. What makes him feel better? Leaning the head away, leaning to the side like this. Like this is such an issue for you that you're having trouble sleeping with it, right?
Sure, absolutely.
So even your sleeping position, you have to
I'm trying to sleep in whatever position feels good.
Yeah. Okay, so one of the key things that this patient's already told you, he leans to the side like this, he leans away, that's going to be better. What was one of the key recommendations I gave?
To lean away.
Yeah, to lean away. He's already doing it, right?
Yeah.
But what you could do in office for this patient is oftentimes they'll have a very guarded neck motion, is you can have this patient lay down. So I'll have you lay down, Roger, just like we did the other day. Okay. You'll have him lay down, give him a little bit of support to get down here. And the first evening that we actually did this, the first assessment, what we found was that he doesn't even want to straighten his neck back out, right? Like even when you're laying yourself.
No, that's the most painful thing, is just being flat on my back.
Okay, being flat on his back. And we're going to go there.
All right.
Okay. So what we're going to do is we're actually going to distract the neck away like this. Okay, open it up, and slowly we can bring him back into a position. And you're doing okay, Roger?
Mm-hmm. Yeah, that doesn't hurt.
Okay, right there. All I'm doing is a basic cervical distraction to get him back into this position. All right, so that's kind of a quick synopsis of what we went over. There was a few other things, but I'd like to open it up for questions if you guys have any questions or ideas. You guys have been trained by me, so I think everybody in this class right away is probably has a very good idea of what's going on here. Differential diagnosis, what do we think? Okay, so I'm hearing thoracic outlet syndrome. I'm hearing pinched nerve in the neck. Approximately what spinal level? C7. Okay. All right, so something like that is probably going, some type of radiculopathy. We haven't gotten all the way into our cervical spine assessment for most of you, but some of you in the back, we definitely have. Okay. All right. Any other questions for Roger or myself on this one? I mean, it's a good case for you guys to see. The biggest thing for you to get is look how obvious it was that that reflex didn't happen, right? Okay. Now this may not have been picked up by one of the other practitioners who looked at.
Correct.
Okay.
Yeah.
One of the most common errors people make in missing these reflexes is inability to perform the task. Okay. Where do people get this wrong to begin with? Is they pick the wrong tools. Please, doctors at home, don't use a reflex hammer like this. It's too light, it's not a good tool. What does it cost you? $6, $10? It doesn't get the job done, okay? You have to swing, well, he'll actually probably have reflexes because they're so good. You have to swing the hammer quite a bit harder to get the reflexes to happen. And if you're moving around in different positions, it makes it more difficult to make that happen. Get a heavy, solid reflex hammer, maybe $60. It's worth it. All you have to do is drop the hammer and the reflexes occur. Okay, literally the weight of the hammer makes it happen. What else? The basic muscle testing that we did, right? All you're doing is going through your essential range of motion resisted muscle testing. Just follow that basic procedure. You come to these diagnoses way more quickly if you do that. Follow the basic procedures. Interesting thing that's also going on here, though, at the same time, is if we push over top of, where is it exactly? A certain point on your line. You can see the apprehension there. Okay.
Yeah.
A certain point.
Again, like I didn't hurt my arm, but for some reason I want to throw a heat pad on there and massage it. One spot in particular around the middle of my arm there is quite painful. Like right there, that's quite painful.
Yeah, you can feel you draw away. Okay? Yeah, okay. All right.